Well, good morning, everyone, again. Let's get started. There'll be some more people joining us. Uh, Welcome to our 2026 Frontiers in Addiction Lecture Series. I'm Dr. Mo Gelbart, the Executive Director of the Thelma McMillan Recovery Center and the Director of Behavioral Health at Torrance Memorial Medical Center. So we really appreciate you all for being here this morning and for your continued support of these programs. For at least 25 years, we've been putting them on. And as a reminder, we provide 1.5 free CEUs. And if you attend our meetings, you're going to meet most of your licensing CEU requirements. Our next speaker is June 16th is Kathleen Murphy, who'll be presenting on Beyond the Trauma Frame, Reclaiming Sufferings as a Path to Wisdom. So keep a lookout for the flyer and registration. For the second half of our year, our speakers are Dr. Tian Dayton, Healing Adult Children of Alcoholics, Dr. Stephanie Carnes on pornography, Dr. Aaron Wilson on psychoactive substances and psychosis, and Dr. Alan Berger on emotional sobriety. Always want to give a shout out and a thanks to our great partner in this lecture series, the Meadows and Cheryl Canby, and to our team at Thelma McMillan, Torrance Memorial, including Jamie Gelbart, Lee Fitzgerald, and our PR department. And we've been committed to providing important and valuable information to the community in the treatment of addiction and addiction-related disorders. To start our program, I'm going to tell you a little bit about Thelma. Cheryl's going to talk about the Meadows, and then we'll introduce our speakers. Questions and Q&A will be after the program, so put any questions you have in the Q&A box, not in the chat box, please, but put it in the Q&A box. I'm going to answer the first question that will be asked several times. The slides for this program will not be available. So if you want to take notes and so on, just know that the slides won't be available at the end. As far as your CEUs, you're going to get an email with a evaluation when this is over. The system requires that you be on the entire time. So if you leave early, you won't get that email, just so you'll know. A little bit about Thelma McMillan. We've been serving the South Bay for 35 years. I've been a director from the beginning. We're an IOP, an intensive outpatient program. We're part of Torrance Memorial Medical Center and the Cedars-Sinai Health System, a nonprofit facility, and a proud McMillan Family Foundation grantee. In addition to our treatment programs, we have a vast array of community services, including this and other educational programs. We have counselors in all the local high schools. We have free drug testing for teens and lots of educational opportunities for local faculty and parents. We have 3 programs at the hospital: a day adult program, an evening adult program, and a teen after school program. Teen program is 9 months. Our adult program is 9 months. Our teen program is 6 months. And our people continue to come after graduation for, some of them come for 20 years once a week. And that's one of the values of being in an intensive outpatient program, which is in the community where you get sober. We also have a sophisticated hybrid program, so people can be in our IOP without living in the community, and they continue to come if they're on vacation or if they're ill or away. We have a free comprehensive assessment. IOP is, when appropriate, a treatment, actually the treatment of choice. A lot of advantages to being, staying at work, staying at home, staying with your medical treatment team, less expensive, and most important, as I said a moment ago, people get clean and sober in the communities that they live in and develop a support system. When we do our assessments, we make sure people get the best care, and sometimes it's not our program, so we are referring to residential treatment, to detox, to psychiatry, to 12-step, and so on. We're a network for almost all insurances, most recently including Kaiser, and we hope you'll consider us for your patients with alcohol and drug issues, and just know we'll work closely with you. And as I said, I'll put some information in the chat box if you want to get hold of us or come see our facility. With that, I'm going to turn it over to Cheryl Canby.
Good morning, everyone. Thank you so much, Dr. Gelbart. My name is Cheryl Canby, and I'm honored to represent the Meadows. Thanks for joining us this morning and every month. This year is especially meaningful for us as we celebrate 50 years of healing developmental and relational trauma. Over the past 5 decades, the Meadows has built a trusted legacy as a leading trauma treatment center, grounded in our proprietary model developed by PM Melody, which explores the lasting emotional impact of childhood trauma. This model continues to inform and guide all of our programs today. The Meadows provides comprehensive treatment for addiction, dual diagnosis, and primary mental health through inpatient, residential, and in-person intensive outpatient programs. Our inpatient campuses are located in Arizona, California, and Texas, with outpatient centers in 9 locations nationwide. We also offer virtual intensive outpatient programs alongside our in-person outpatient services. In Arizona, our standalone Rio Retreat Center offers more than 15 5-day therapeutic retreats and workshops, as well as private intensives. What truly sets the Meadows apart are our specialty programs, which include treatment for problematic sexual behaviors, porn addiction, love addiction, eating disorders, process and compulsive disorders, codependency, and relationship and intimacy issues. Our trauma-informed modalities emphasize brain and nervous system regulation through somatic therapies, supported by our Meadows Brain Centers, which provide neurofeedback and biofeedback services on every campus. We're also proud to expand our access to care. Our Arizona inpatient programs and select IOP locations are in network with TRICARE and TriWest, allowing us to serve active duty military service members, veterans, and their families. In addition, all Arizona inpatient programs, including our flagship and specialty programs, are now in network with Blue Cross Blue Shield, and we continue to work with out-of-network insurance to increase access to our specialty care. Alongside PMLD's enduring legacy, our clinical work is informed by the Meadows Senior Fellows, including leaders such as Bessel Vanderkolk, Peter Levine, Patrick Carnes, Dick Schwartz, Claudia Black, and Kevin McCauley, among many others who help shape the future of trauma treatment. I invite you to learn more at themeadows.com. I'll also share my contact information in the chat. I also want to emphasize how important our relationship is with the broader clinical community. We actively refer to specialized clinicians for clients discharging from our programs, as we value collaboration and continuity of care. As we celebrate 50 years at the Meadows, we remain deeply committed to evolving our clinical work, advancing trauma-informed treatment, and continuing to collaborate with clinicians like you to support lasting recovery and relational healing. Thank you again. My name is Cheryl Camby with the Meadows, and I'll turn it back to Dr. Gelbart to introduce our speaker.
Thank you, Cheryl. So it's my pleasure to introduce Dr. Mark Hrymoc. Dr. Hrymoc has extensive expertise in the psychopharmacology of addiction and other mental health disorders. He is double board certified in general psychiatry and addiction psychiatry, and was previously board certified in addiction medicine. Dr. Hrymoc was assistant clinical professor of psychiatry at UCLA, where he supervised training psychiatrists at their addiction psychiatry clinic. He completed his subspecialist training in addiction psychiatry at Cedars-Sinai Medical Center in Los Angeles, and currently serves as a consulting physician to several prestigious drug and alcohol treatment centers in the area. Dr. Hrymoc co-authored a chapter in Principles of Addiction Medicine, the main textbook of the American Society of Addiction Medicine, and has been published in several academic journals. With his wife Ellie, also a psychiatrist, he founded the Ketamine Therapy Center as a promising solution for treatment-resistant depression, anxiety, trauma, and other mood disorders. It's my honor to introduce Dr. Hrymoc.
Thank you so much for that warm introduction, Dr. Gelbart, and thank you for having me. So today's talk is entitled Ketamine and the Next Wave of Psychedelic Medicine, Clinical Perspectives and Research Insights. So the first half will focus on ketamine because that is the currently available medication that we use in our clinic, is being used nationwide. But I know there's also a lot of interest and a lot of news coming out almost on a daily basis about psychedelics that are showing a lot of exciting results in research studies, and very likely we'll start seeing FDA approvals of in the next few years. So definitely an exciting time to be a psychiatrist and to be working in mental health in general. All right. So why care about ketamine? All of us have treated patients, clients that hit a point where they just don't seem to get any better. And even after a number of medications have been tried or types of psychotherapy have been tried. So these are the cases where ketamine can jumpstart progress again. Most research supporting its use is for treatment refractory or treatment resistant depression, in particular in those with suicidal thoughts and behaviors. But as you see, it can also be used for depression associated with bipolar disorder and also serve as an augmentation agent for psychotherapy. And there's more evidence coming out about its use in anxiety disorders, including PTSD, OCD, and even some promising research in its ability to treat substance use disorders. What makes ketamine a great antidepressant? It's fast acting, often working after just 1 or 2 treatments, as opposed to the 4 to 6 week waiting period we'll experience with an SSRI or other similar antidepressant. It has a unique target, works on glutamate, so that's the neurotransmitter associated with stress and toxicity. So not the typical serotonin, norepinephrine, dopamine that most traditional oral antidepressants hit. It's in general well tolerated with minimal side effects. It also has anti-self-harm benefits, which most people are surprised to find out we don't really get with traditional antidepressants. They're only the only medicines in psychiatry that actually reduce rates of suicide are lithium and clozapine. So ketamine is a third one now. And has a very high response rate in treatment-resistant depression. In someone who has already tried and failed a number of antidepressants, their chance of benefiting from yet another one is something like 15%, whereas in that tough-to-treat population, ketamine can help 70% or so of people. So ketamine is an interventional or procedural treatment for treatment-resistant depression, and this chart shows it compared to the other main interventional treatments in psychiatry, RTMS, which is repetitive transcranial magnetic stimulation, and ECT, which is electroconvulsive therapy. So all of these stimulate the brain in some way, but differ in the mechanism by which they stimulate the brain. So ketamine is a medication that stimulates the brain, hopefully to get a person out of a depressed state. TMS does the brain stimulation using a magnetic current, and ECT uses an electrical current. Um, a benefit of ketamine is that it actually requires a relatively low number of treatments compared to the others, and a full course of treatment is done in half the time. So ketamine, the typical induction phase is 6 sessions done in a 2 or 3 week period, and RTMS requires 20 to 30 treatments, usually done as 5 treatments a week for up to 6 weeks. And ECT is 3 treatments a week for 4 weeks. A downside of ketamine is the fact that it is not covered by insurance. So the reason for that is ketamine is a generic medication that came out in 1970. So no pharmaceutical company ever had the profit motive to do the millions of dollars worth of studies to get formal FDA approval. So insurance will put up a fuss about paying for it. In our experience, the only insurance company that will cover IV ketamine is Kaiser. And so we actually do work with Kaiser Permanente to treat their patients with IV ketamine. Um, Side effects in general, ketamine can affect coordination for a few hours, so people can't drive home after their visits. TMS is very compatible with being productive the rest of the day. A person can get a treatment and then go to work or school afterwards. ECT, you basically have to take the month off because of significant memory side effects, so that they do differ in their side effects. And in the response remission rate, you'll see something like 70% for ketamine and TMS, ECT 80%, often considered like the most effective for people that are struggling with issues that can't be addressed with other means, but also the one that has the highest side effect burden. So this was one recent study comparing ketamine to ECT, and the take-home message was that outpatients with moderate to severe non-psychotic treatment-resistant depression did really well with ketamine. For the most severe cases of severe depression or people that are inpatient hospitalized for depression, ECT may have had a slight edge. But this really just goes to show that ketamine is nearly as potent of a treatment for treatment-resistant depression as what we often consider the most intense treatment that psychiatry has to offer, ECT. Yet again, it is really well tolerated. So ketamine has both brain and mind effects. It biologically it reduces activity of the toxic stress neurotransmitter glutamate and increases the healing factor that promotes nerve growth, BDNF, brain-derived neurotrophic factor. And it's that factor that stimulates neuronal growth and plasticity. So brain cells growing and forming branches between them. I think of it as like a natural fertilizer for the brain. Um, Besides having biological activity, though, ketamine also works in an experiential way. A person does feel different when they get a ketamine treatment. Some of the things we hope they experience are an increased sense of hope. In the different state, people can feel more hopeful. There's a dissociative quality to ketamine, which even be deemed like a positive type of dissociation where they're able to see things from outside their lives, maybe even in a more, quote, objective way. They commonly can have spiritual or psychedelic experiences. There are also lowered ego boundaries that could enhance the connection that they feel with their therapist and others as well. And we'll talk a little bit more about augmentation of treatment with therapy. Um, you know, this is a recent study basically showing that a single infusion of ketamine reduced depressive symptoms significantly at 4 hours, 24 hours, 3 days, and 1 week. And so it's, again, very fast acting. Also, in addition to the antidepressant effects being very fast, their anti-suicidal effects also came really quickly at 24 hours and persisted up to a month after even just one treatment. We'll give 6 treatments to make the antidepressant effect last longer than just a week or so, but it was noteworthy that with one treatment can help prevent the suicidal thinking or behaviors for even up to a month. So you could read that kind of bottom line on your own. One of my favorite slides showing the neuroplasticity associated with ketamine. So these are neurons or brain cells in an animal model of depression. The first slide on the left shows a healthy, robust cell with many full dendrites or branches on that cell. And the second shows that neuron after 21 days of stress. So you could see thinner, skinnier, and less of the dendrites and or branchings. And then that last slide on the right shows what happens to that middle brain cell after just one ketamine treatment. So a day later, that cell appears vibrant and flourishing again. So the default mode network is the circuitry in your brain that handles automatic rehearsed processes like driving a car, Depression and anxiety can present with perseverative thoughts like, I'm not good enough, or I'm a fraud, things will never go my way. Ketamine and other psychedelics we'll hear about later also has the ability to reduce or dissolve this preconceived programming by disconnecting the limbic and cortical regions of the brain. A little history on ketamine. In 1962, it was discovered by Calvin Stevens. Um, Human studies were run, and Dr. Domino running them was the one that coined the term dissociative anesthetic. It was FDA approved in 1970, and because it was very safe and short acting, quickly became the most widely used battlefield anesthetic in the Vietnam War. So this is a common question. Isn't that horse tranquilizer? Um, and the answer is technically yes, but also it is used in humans, including children. It is a safe anesthetic used for kids under the age of 12, especially in emergency rooms where they may need to be sedated to get a procedure like stitches or something else that could be painful. It has an excellent safety profile because unlike other anesthetic agents, it maintains cardiac output. It doesn't suppress a person's beating of their heart or their respiratory drive or airway reflexes. And because of that, it's on the World Health Organization's essential medicines list and ultimately is the most widely used anesthetic worldwide. These are some pain syndromes treated by ketamine. Noteworthy for pain syndromes, especially CRPS, they'll use much higher doses of ketamine over much longer periods of time. So the infusions that we do for ketamine are 40 to 60 minutes, whereas for CRPS, people will have something like 4 to 8 hour infusions using much higher doses. But ketamine can also be used in a topical way. It sometimes is an ingredient put in creams for neuropathic pain. It can be used for migraines, fibromyalgia, and phantom limb syndrome. So the best term to describe what type of medicine ketamine is, I would say, is it's a dissociative anesthetic with psychedelic properties. So if we break that down, um, dissociative is anything that causes a disconnection or separation of one's body and mind. So a person feels like they're floating or maybe not in their body anymore. They might feel like they're dreaming, etc. As I said before, some of that could even be beneficial or anxiolytic if the goal is to process and work on trauma that might be painful and cause a reflex of suppressing or denying. Um, in general, it is an anesthetic technically, but we use sub-anesthetic doses, 5 to 10% of what a person may be given for anesthesia applications. And it also is a psychedelic. So that comes from the Greek, psyche meaning mind, and delin to manifest. So it's thought to be mind manifesting or allowing a person to access untapped aspects of the mind. An important distinction is we won't say that a person is in an altered state of consciousness or impaired. That's more of terms that we might use for, intoxication or something that, is seen like in a negative setting or in a recreational setting. When it's used in a medical setting and especially in a therapeutic way, the term we'll use is a non-ordinary state of consciousness, because the patient is not just numbed out like they might be on alcohol, benzos, or opioids. The goal in general is for them to feel more open, empathic, able to be vulnerable, and actually process and work on their mental health issues. What does ketamine feel like? Uh, People will describe initially feeling relaxed, lower defenses, a sense of empathy, warmth, joy, that separation of their mind from sensory input. Um, they're still able to process trauma and painful emotions without the reflexive emotional pain that would normally prevent them from talking about a painful experience. Yet they still can experience sadness, tears, joy, empathy, as if the increased empathy and perspective shift they experience on ketamine exceeds their default pain, anger, and fear that may typically accompany that traumatic memory. So this enables them to reflect on trauma in ways they wouldn't normally be able to do. Also, with ketamine on board, if a patient feels uncomfortable or distressed by a topic, they can more easily shift their attention to a different subject rather than spinning out and feeling increasingly dysregulated by a traumatic memory. So this is a slide showing the chemical structure of ketamine. Uh, Generic ketamine is a mixture of these two. When a medication is made in a laboratory, we get both the right and left-handed versions of the molecule. So they are not identical, but they are mirror images, just like our right and left hands are mirror images of each other. So generic ketamine is a 50-50 mix of these two enantiomers, whereas Spravato is just S-ketamine. So we'll talk a little bit about Spravato. Um, so this is the FDA approved nasal inhaled version of ketamine. Um, the schedule for this is 2 treatments a week for 4 weeks, then 1 treatment a week for 4 weeks. That's considered the induction series. So you'll see it actually requires twice the treatments of that IV ketamine does. And that's part of the reason it's thought to be a somewhat weaker type of ketamine because it requires more treatments to show effect and to maintain benefit. And then the booster schedule is determined as needed. It is FDA approved for treatment-resistant depression in adults who failed at least 2 oral antidepressants and depressive symptoms with major depressive disorder and accompanied with acute suicidal ideation or behaviors. So it actually is FDA approved for suicidality, not even just depression. And in January of 2025, it was approved as monotherapy. It can be given on its own before it needed to be given in conjunction with an oral antidepressant. It is highly regulated, more regulated even than IV ketamine because it was a condition of its FDA approval. So there is a REMS program, which is a restricted distribution program. Notes from each session have to be faxed to the REMS center within 24 hours, and healthcare settings need to be certified. And so there are requirements like that. So why did MHC start the Ketamine Therapy Center? We saw definitely a solid evidence base for ketamine for treatment refractory depression. Most notably, the triggering moment was the FDA approval of Spravato in early 2019. That's really what got us moving to create our own ketamine clinic. There were ketamine clinics that existed before then, but we noticed many of them did not incorporate psychiatry or psychotherapy. Many would have a low bar for entry, even offering ketamine as a psychedelic adventure for anyone interested. We do take our positions as licensed healthcare professionals in California very seriously and really do aim to treat people that have depression, anxiety, and mental health issues, and not only as like a recreational experience for a person. So we strive to be an ethical ketamine center where every patient gets a formal psychiatric evaluation. We also discuss non-ketamine options like therapy and conventional medications. We communicate and collaborate with treatment teams, especially important for these patients who are often the toughest to treat patients. They'll often have therapists or other IOPs or programs that they're working with. And so we all understand what it's like to treat tough patients and the importance of collaborating on those cases. And we also have a one-to-one staff to patient ratio during treatments because we all certainly heard of people having negative experience where they're given ketamine, but then left in a room alone, monitored with a camera, but they're one of 4 rooms, maybe, monitored by one nurse. And so, yeah, we do have a one-to-one staff to patient ratio in our clinic. The consent process for ketamine includes an acknowledgement ketamine works quickly, but one session lasts 1 week. Improvement does last longer with 6 treatments over 2 or 3 weeks. Then, after that induction series, booster sessions are often required. Usually, every 1 to 3 months is what I'll tell patients. Some benefit for as long as 6 to 12 months. That's more the exception rather than the rule. And generic ketamine is technically off-label, not FDA approved, and not reimbursable by most commercial insurance plans. What are the side effects of ketamine? Already discussed the dissociation. Nausea can happen. That's the reason we actually recommend no food in the 4 hours before and no drinking in the 1 hour before. And small sips of water or something light to eat is okay, but it's really just about minimizing the food in the stomach to just help reduce any nausea being triggered. And with that, most people don't experience any problematic nausea. Well, we can also give them Zofran, which is an anti-nausea medication IV during their treatment as well. Heart rate and blood pressure can go up somewhat, sort of like climbing 2 flights of stairs. So usually it's mild and it's monitored, but we just want to make sure no one has uncontrolled high blood pressure. People may experience illusions or dreams that may seem real. I'll talk a little bit about ketamine-assisted psychotherapy. I see a comment on or a question on that already, so we are getting to that. And rare side effects can include inflammation of the bladder, which is more often seen in people who are abusing it recreationally in large amounts over long periods of time. With any antidepressant, including ketamine, a paradoxical result is possible where a person can actually feel lower or even experience suicidal thoughts. So that's always something that we monitor for as well. So these are the safety precautions. No driving rest of the day. So we encourage a person to have a friend or family member pick them up, especially after the first treatment when before they're familiar with the medicine and what effects it has on them. But Uber rideshare works just fine for the majority of folks as well. And we do administer a urine drug test at the beginning of every visit, mainly to make sure there's no surprises there. We never want ketamine to be a part of someone's cycle of abuse or addiction. The goal always is to do no harm in medicine. And we want to know that people are also open about what substances they may use. A lot of people obviously are using cannabis recreationally or alcohol recreationally. I mean, so we just ask them to abstain in the day before, but in general, there's not like a significant or toxic reaction with commonly used substances and ketamine. So contraindications or cautions, if someone is currently manic or psychotic, they should not receive ketamine. If they are in active addiction or pregnant, glaucoma, 'cause ketamine can raise intraocular pressure. So that's another thing that would need to be addressed before we would give ketamine. Any tumors or lesions in the brain, and then a recent history of bladder issues, especially cystitis, inflammation of the bladder. We just don't want ketamine to worsen that in any way. So Ketamine ultimately does have a low addiction potential in medical settings. So there is a key distinction to make. A medication being something that is prescribed with therapeutic intent. There's a healthcare professional involved. It's also making decision that is the person that's making decisions, collaborating with the patient. But whereas a drug is self-administered, so that by the patient in a non-monitored setting, and so the context really matters in which a chemical is used. Those are some quotes, one from a study, and the second, which is a consensus guideline from three major anesthesia and pain organizations there. Several studies even show promise for ketamine in cocaine and alcohol use disorder, and ketamine and esketamine are currently being studied for the treatment of alcohol use disorder by a company called Solovanis. Some medications may blunt ketamine's antidepressant benefit. So there are case reports of this. It hasn't been clearly established in high quality research, but there are enough people that reported it that most clinics, including ours, recommend holding these medicines for 12 to 24 hours before a treatment, as long as doing so wouldn't make them worse. So the common one is like benzodiazepines. If someone does take Klonopin every morning for anxiety, and without it, if they would be anxious, we actually would recommend they just take their Klonopin as usual, because we also want them feeling good when they're walking into a treatment and not struggling with, anxiety or anything else destabilizing. So ketamine-assisted psychotherapy, or CAP, is a type of psychedelic-assisted psychotherapy. And so for any of these psychedelic medicines, there is a lot of interest in the role of therapy combined with the medication. So CAP is psychotherapy that occurs during the ketamine medication session or after the medicine session, the same day or even the next day counts as a ketamine-assisted psychotherapy session. I'll talk a little bit later about preparation and integration sessions, which are outside of those windows, but this refers to the medication sessions within CAP. During those treatments, people will have lower defensiveness, more openness to change. The dosing of ketamine is often lower for people engaging in therapy because we want them to be able to speak and participate more fully. That becomes tougher as the dose of ketamine goes up. The standard starting dose for ketamine, even without therapy, is 0.5 milligrams ketamine per kilogram body weight. So it is dosed by body weight. In our clinic, we'll give ketamine anywhere between 0.3 to zero point 0.5 if they're starting CAP. They're often able to go to somewhat higher doses. We have a good amount of people going up to 0.7, 0.8, not really beyond that, though, if they're doing psychotherapy, because it literally does become tougher for a person to talk and to be able to fully meaningfully participate in therapy during the whole experience. So psycholytic dosing is the lower doses, and then psychedelic dosing are the 0.5 to 1.5 milligrams per kilogram, which is the max dose that we would give in our clinic. And doses at 2 and above are considered anesthetic doses. So again, like we're in the sub-anesthetic realm, and 4 to 10 milligrams per kilogram are usually are used in like real anesthesia settings. Psycholytic is a term meaning mind loosening. So some dissociation occurs, but patients maintain their capacity for dialogue and awareness of where they are. So CAP differs from traditional psychotherapy because there is an actual medication experience to process. So a person has an experience or goes on a journey, we'd say. They can explore the meaning of images, visions, themes that they experience. They anchor back to the original intention that they might have had for that session, and we'll talk more about that later. And the 36-hour window is thought to be the window of neuroplasticity where ketamine ketamine treatment can help therapy or make therapy better in up to 36 hours after it's given. And then there's re-entry and integration after the medication sessions, where the goal is to implement insights as enduring life changes. We always recommend self-care for kind of the rest of the day, taking it easy, journaling, music, being in nature are all recommended things. Try to avoid stressful things like, deadlines or going back to work or anything that same day. So this is a study by Wilkinson and his group at Yale, where all subjects received ketamine in the first 3 weeks, and then the responders were split into two groups, those that received CBT and those that didn't. CBT was chosen because it's a very manualized or standardized form of therapy that can be replicated. With the passage of time, they found that those continuing therapy actually experienced the benefit of ketamine for longer than people who didn't. So that's where the depression severity for the orange line, the CBT line, is lower in the 17th week than the blue line, which is treatment as usual. There was a nice meta-analysis on ketamine-assisted psychotherapy that came out this year. There were only 11 randomized control trials. There were many more case reports, so a lot of anecdotal evidence, but there were only 11 trials where they controlled for ketamine and an active placebo, but not for psychotherapy. And so the studies really differed in their quality, and it was tough to actually even discern what is the benefit of psychotherapy being added to ketamine because of that. These studies did observe benefits for addiction, depression, and the rest of the disorders there. But definitely a lot of open questions remain on the combination of therapy and ketamine and whether this is a purely additive effect or like a synergistic, 1 + 1 = 3 effect, where the sum of the two is greater than the individual parts, and also protocols would need to be standardized. So there is not a lot of great evidence on ketamine-assisted psychotherapy, and when it's offered now, it's mainly offered on the premise of a belief that this, or experience that this is helpful or that this has been helpful. And there are definitely a lot of clinicians in the field and individual patients that really did think that this made the difference. Adding CAP to their ketamine treatments really made a difference for them. So in our clinic, there are 5 steps, and I'll go through them kind of one by one. So, the route of administration is a choice. IV is the gold standard. That's the dose infused over 40 minutes. 99% of the medicine gets into the system with an IV route. It's nice that the infusion, the slow drip of medicine into the system, can be stopped if a person wants that. Realistically, it's rarely necessary. Maybe 1 out of 50 patients getting an initial treatment with us ask for that. It is a very well tolerated treatment, but even just that reassurance is nice for folks to have. Another route, especially if a person has bad veins or they just don't like the idea of an IV sitting in their forearm, is to get an injection in the shoulder, much like a vaccine or any other shot. So same dose can be injected, resulting in 95% of the medicine getting into the bloodstream. So pretty comparable to IV, although it is a faster onset, a higher peak, and a shorter duration. Sometimes we'll split the dose into 2 different injections, 15 minutes apart, to mimic kind of the longer, flatter curve of the IV treatment. Spravato is an option as well. So 2 doses there, 56 or 84 milligrams. About half of it gets into the system, so it is a less bioavailable route. but it is FDA approved and can help with depression, suicidal thoughts or behaviors, just like generic ketamine can. And people will often ask about like ketamine lozenges or troches, they're called. We rarely use these because they are the least bioavailable, 30 to 40%. There's the least evidence supporting its use. It requires a very reliable patient because a person is, given these troches or lozenges, home and, they're self-administered. So the patient selection is really important. But it can be considered like a mini infusion, basically. So choice of sitter, the person that is with you. So by default, we'll have a nurse sitting with a person, but if they choose to have a therapist, then we'll have the nurse actually step out of the room, but still monitor the patient vital signs with a Bluetooth connected vitals monitoring system that we have. And this gives the patient and therapist privacy, and for them it ends up hopefully feeling much like a typical therapy session in that way. And the nurse is basically responsible for monitoring the health of the patient during the treatment and the medical safety, whereas the therapist is the one delivering the ketamine-assisted psychotherapy. So preparation happens before the medication session. All patients are told to bring an intention or something to work on during their session. Informal CAP, there are a few sessions before medication even gets into the picture, and the therapist learns about the patient. Patient and therapist build trust and rapport, just like any other psychotherapy. Expectations are set for medication sessions. We tell them to bring the following. Music is important because it can help guide an experience, but we don't want too much structure there since we want a person to be open to wherever the medication may take them. So we tend to recommend music without heavy beats or vocals like ambient or classical music. And this is the journey, also known as the medication session, where the ketamine is administered. The main part of the experience lasts 90 minutes, and the patient is in our office for 2 hours total. The slide on the left shows CAP, so with a therapist there offering a reassuring touch to the patient. And that is a modality that is sometimes employed in psychedelic psychotherapy, always with permission and consent and discussion beforehand, because the patient is in a vulnerable state. And that's something we'll talk a little bit more about later. And so this gentleman on the right is actually wearing the caretaker device that we use, which is the device mounted on his wrist that has the heart rate and blood pressure monitored with a finger cuff. So, and then the last stage during the integration time period, we want patients to take the insights gained from their experience and implement them in their lives as enduring positive changes. And if they're doing formal CAP, they'll have an actual session with a therapist to assist in this process, and ultimately then preparing for the next medication session. We encourage all patients to practice good self-care and engage in reflective or creative activities like journaling, music, art, and encouraging everyone to strengthen their connection to nature and the world we live in. So in summary, when to consider ketamine for a patient, if there's treatment-resistant depression or bipolar depression, or suicidal ideation or behaviors, current medicines not giving adequate relief or being accompanied with intolerable, unsustainable side effects, and growing evidence for anxiety disorders and potentially for substance use disorders. Or in general, if a patient is stuck in psychotherapy, ketamine can be a catalyst for renewed progress. These are some take-home points. References. All right, so second part is on the psychedelic renaissance in mental health. So, um, in the last 60 years, we've experienced a big shift in the way that psychedelics are regarded in our society. Everyone has heard of the stories from the 60s where many psychedelics were used and the hippie movement. Before they were actually made illegal in 1970 via the Controlled Substances Act under Richard Nixon. So that's where LSD and psilocybin were classified as Schedule 1 by the DEA, which means dangerous and no approved medical use. MDMA was later, 1985. So Nixon's war on drugs effectively halted research in this field for more than 30 years. There was a lot of cultural stigma as well. It made funding and IRB approval for studies nearly impossible. And there were still some researchers that worked with these compounds on an underground basis, but nothing, above ground that could be published and spoken about in conferences and all those other things that are necessary for science to really develop. And so now we are well into the psychedelic renaissance and have come full circle. Um, a lot of research started being done in actually 1999, 2000. But the key milestones recently have been the FDA approval of Spravato in 2019, and also MAPS, which is the organization that was sponsoring the MDMA trials for PTSD, was conducting studies through 2024. And then Compass Pathways is the major pharmaceutical company with a patented version of psilocybin currently in phase 3 trials. A RAND study from this year said that 11 million adults in the US used psilocybin in the past year. And in Oregon for the last 3 years, and Colorado for the last 2 years, there's the first legal supervised psilocybin access for healthcare use. So this is the psychedelic drug development tracker, which Psychedelic Alpha puts out. It's a fascinating slide where I don't expect you to be able to read the things in the middle. I'll zoom in on a little bit, but the main point here is to see how many different medications are currently in various stages of study and approval. So that center circle in purple are the medicines that are approved. And then the concentric circles that go out from there are phase 3, followed by phase 2, phase 1, and then discovery and preclinical phases are the outermost circle. So these are all of the compounds and the pharmaceutical companies that are sponsoring those studies. Um, so this is a zoomed in version of that. And so you'll see in the middle is Janssen's Spravato, FDA approved for treatment-resistant depression and MDD, major depression. And then outside of that, you'll see ketamine being studied for alcohol use disorder in phase 3, LSD for MDD and GAD, and we'll talk a little bit more about that later, and MDMA, psilocybin. So these are all, phase 3 nearing potential approval. And this chart shows these same medications and companies sorted by disorder that they're addressing. So you can see depressive disorders are responsible for nearly half of the research interest here. Anxiety, substance use, significant amounts, maybe like a sixth each. PTSD, somewhat below that in the other category. So all major psychiatric disorders, especially the non-psychotic ones, because those are an exclusion criteria, are there are psychedelics currently being studied for. So psychedelics are not one class. They do differ fundamentally in their duration and therapeutic profile. Um, Classic psychedelics are the ones that stimulate the serotonin receptor, specifically the 5-HT2A receptor. And those are psilocybin, LSD, DMT, and 5-MeO DMT. Atypical psychedelics include ketamine, but also MDMA and ibogaine. And what they all share are the non-ordinary states of consciousness. They enhance neuroplasticity. There is this model of preparation, journey, and integration. So the psychedelic assisted psychotherapy being a part of it, the set and setting, the mindset of a person, and the physical setting that the treatment is delivered, having a critical impact on the quality of the treatment and the comfort of the patient is vital there. And the therapeutic benefit can often happen from a single or just a few doses. Key terminology, oneirogen is something that induces a dreamlike state. So ibogaine is the main compound that is classified as an oneirogen. Entactogen is a term that means touching within. So these are substances that produce a sense of interconnection or self-awareness. MDMA and then related compounds, MDA, are ones that are considered entactogens. And it's really those same compounds tend to be empathogens, but that word uh, corresponds to the role of them to generate empathy, pro-social bonding, and emotional closeness with others. I majored in organic chemistry and also psychology, so I've always liked the chemical structures of these medicines, and noteworthy that they are all based on tryptamine, which is the precursor of serotonin. And so A in the top left there is serotonin, 5-hydroxytryptamine. And you'll see psilocybin is B, and psilocin, which is the primary metabolite and active compound that psilocybin is converted to in the body, is C. So again, yeah, very similar to serotonin, differing only by the groups that are added at this position here. D is DMT and E is 5-MeO DMT, so dimethyltryptamine and 5-methoxy-dimethyltryptamine. DMT is the active ingredient in ayahuasca, and F is LSD. And even though it's a much more complex molecule, you'll actually see the same familiar tryptamine base embedded in that molecule there. Functional unblinding is very relevant for psychedelic researchers because it really makes studying them with double-blind, placebo-controlled trials difficult. Patients, and the investigators administering the medicines are not supposed to know if someone got an active medication or placebo, but in a typical placebo-controlled study model, it is very easy for everyone to tell like what they got, and that can create expectancy bias. You know, if a person thinks that they got the medicine, or a nocebo effect, which is a disappointment that can lead to worsening symptoms if they don't feel different at all and they think that they didn't get the active drug. So basically can compromise the ability to prove that the drug is the active ingredient and not the expectation of the drug. So there are ways to mitigate it. So they'll use active placebos. So midazolam, which is Versed, a benzodiazepine, is sometimes given instead of ketamine in the ketamine studies. Niacin can cause facial flushing, so that still can trigger some physical reaction. Blinded raters, so using offsite raters, or end of study surveys, like where they'll actually try to measure the unmasking effect that may have happened for a subject in a study. So this is the regulatory landscape. Currently, federally, all of those substances are illegal, no approved medical use. Um, and so a Schedule 1 by the DEA. And then there are a few that have the breakthrough therapy designations by the FDA, which is ultimately a fast track by the FDA for review of the research to hopefully result in a quicker approval. So MDMA notably got denied FDA approval in August of 24, and they are working on new phase 3 trials. The state landscape includes the measures in Oregon and Colorado for psilocybin being available. In Colorado, after June, DMT, ibogaine, mescaline can also be used in those settings. And personal use has been decriminalized statewide for adults 21 and up with all those substances there. And then Texas is currently funding a $50 million ibogaine research program. It's the largest psychedelic research initiative in U.S. history and targets PTSD, TBI, and opioid addiction in veterans. So psilocybin. These are the variety of mushrooms in the psilocybe genus. Psilocybe cubensis is D, so that's the oh, sorry, no, E. So that's the most common one that people might use, but there are over 200 species of psilocybe containing mushrooms. So what is it? It's converted to psilocin, as I mentioned before, to be active and has been used for thousands of years by indigenous Mesoamerican cultures. Modern history, it was isolated by Albert Hofmann in 1958, same guy who discovered LSD. And it was studied in Tim Leary's Harvard Psilocybin Project, but that all got halted with the Controlled Substances Act and the thawing of the moratorium on psychedelics, evidenced by those last two bullets there. Key facts. 20 to 40 minutes oral onset, and the duration is 4 to 6 hours. So this is relevant for any potential treatment logistics. So especially with a therapist involved, all of these treatments can be pretty expensive because they require 1 or 2 therapists to be present for the duration of the treatment. Typical therapeutic dose of psilocybin, 25 milligrams. That's the Compass version of it. Works as a serotonin type 2A partial agonist and also type 1A agonist. And the primary use is there below. So key study, Compass phase 3 showed a 39% reduction in depressive symptoms as measured by the MADRS. 26-week benefit, so a durable, long-lasting benefit after just 1 or 2 doses, with rapid onset of antidepressant benefit in 1 day, and likely there'll be a new drug application for the FDA in the last quarter of this year. So it's the first classic psychedelic to consistently achieve statistically significant phase 3 results across 1,000 participants in treatment-resistant depression. Another study looking at psilocybin-assisted therapy specifically for major depressive disorder. This used 2 psilocybin sessions, 20 milligrams, then 30 milligrams. And the control in this trial was a waitlist control. So they addressed the functional unblinding problem by eventually making sure everyone got the medication, but half the subjects got it before in the first part of this study, and then the other half got it in the second half of the study. So that was how they addressed it. And every one of these studies has to address the functional unblinding issue in a certain way. So effect size 2.1, extremely large by psychiatric standards, and improvement was maintained at 1 year follow-up in 54% of patients. Um, and this was the first demonstration of medication, of it being used in a non-treatment resistant population. So this was only studied for major depressive disorder. So psilocybin, clinical applications and safety. I'll go to the contraindications, cautions part. So again, we want to avoid in people with history or even family history, and for the purposes of the studies, family history of psychosis or active suicidality. Lithium combined with serotonergic psychedelics can dramatically increase the rates of seizure. So any person taking lithium is excluded from these treatments. SSRIs and SNRIs may blunt the response of the medication, so that just needs to be addressed, if not excluded, for the purposes of the studies. And then psilocybin can mildly raise heart rate and blood pressure, and pregnancy, should be avoided. Side effect profile, HPPD is hallucinogen persisting perceptual disorder, which is rare, but basically hallucinations or other psychotic symptoms that potentially can last longer than the 4 to 6 hours that we would expect. I'll just move on because I know we're running short on time. So MDMA, known as ecstasy and Molly, not a classic psychedelic. It is an entactogen or empathogen, first synthesized 1912, ultimately became popular in the therapist community in the 70s and 80s, widely used in couples and trauma therapy before it was made illegal in 1985. And then August 24 was the rejection by the FDA requiring more phase 3 studies. Key facts, duration, 3 to 5 hours. So again, better part of a day is the length of treatment. And mechanisms works through release of serotonin, dopamine, norepinephrine, also some reuptake inhibition of those neurotransmitters, and oxytocin being released, which is thought to be the pro-social bonding neurotransmitter used in PTSD, perhaps social anxiety or autism, if we think of the bonding capabilities of that, or in couples therapy. So this was a dramatically positive study that really showed the benefit of MDMA for PTSD. Yeah, and it's thought that the release of all these neurotransmitters, serotonin, dopamine, norepinephrine, really can help with the processing of traumatic memories without overwhelming the fear response. And that's the mechanism by which it can help with PTSD in particular, which does not have any FDA-approved options. So that's also why MDMA's study for PTSD was really important. Hyperthermia can exist as a risk primarily in recreational settings, so crowded, hot, dehydrated settings, usually not seen in a medical context. So, the FDA setback, it was rejected in large part because of the functional unblinding part of things. There was also a trial site that had ethical violations. That from the FDA standpoint, there was insufficient data to conclude that the drug was safe and effective. They really got stuck on the therapy being a part of it too, and that caused a lot of kind of delay, hesitation on the part of the FDA. And to ask MAPS or Lycos, which is the new name for the organization about it, they will say the FDA moved the goalpost, and they knew about the therapy being included, but and that was approved with an action in 2017, but ultimately was part of the reason the FDA gave for it not being able to be approved. So Lykos encountered a 75% workforce reduction, needs to do more studies, and still does have a breakthrough therapy designation, though. LSD, interestingly, um, is being studied for GAD, primary uses, and I'm going to go more quickly through this one. And most people are surprised that LSD would be studied for anxiety because it's well known to sometimes have anxiety as a potential side effect. But ultimately, that also there's an example of a differentiation of a drug from a medicine. And so, with proper preparation in a medical context, it can actually even be used to treat anxiety. So this was the one study that looked at it for GID, and ultimately a single dose of LSD resulted in weeks-long reduction of anxiety, 100 micrograms being the main therapeutic dose. So it's the most potent psychedelic, active on the microgram level instead of milligrams. And there are phase 3 studies that we'll see results of at the end of this year. So DMT and 5-MeO DMT. DMT is given IV, whereas 5-MeO is a buccal film that a person takes. Both are very potent and both are very short acting, lasting 20 to 40 minutes each. So these hold promise mainly for the logistical aspect of things. And you could see the duration of the actual treatment sessions there, much shorter than psilocybin or MDMA. So ibogaine comes from the Tabernath iboga plant found in West Africa. It's the one that's an oneirogen, not a classic psychedelic, does not act primarily via the serotonin receptors used for millennia by the Central African Bwiti people. And people describe it as an experience described as facing yourself. Howard Lotsof in 1960 did a lot of self-experiments and discovered dramatic opioid withdrawal interruption. And yeah, key facts. This is the longest duration psychedelic, up to 36 hours. Currently illegal in the US, but there are treatment centers outside the US, Mexico, South America, Central America, where people do go to receive treatments. And I'm just going to wind down, but it has complex mechanisms of actions. There is a significant cardiac risk, so it needs to be administered with magnesium and monitored via EKG. There was a popular study looking at 30 special ops vets with TBI, and they found dramatic reductions in PTSD, depression, anxiety after a single treatment. Sorry. Just want to talk about microdosing 1 minute, basically. What is microdosing? A very small subhallucinogenic dose of a psychedelic, typically 1/10 or 1/20th of a dose. So 5 to 20 micrograms of LSD or lower doses of psilocybin taken on a regular schedule, for example, every 3 days for weeks or months. There are claimed benefits of improved mood, creativity, focus, but the evidence is actually mixed. Placebo effects could account for much of the benefit, and tolerance can develop rapidly. Long-term safety has not yet been fully established. And this is James Fadiman, the father of microdosing, wrote a number of popular books, including the Psychedelic Explorer's Guide, which really ignited mainstream interest. And he had the Fadiman protocol, which is a dose on day 1, skip 2 days, and then repeat 4 to 8 weeks. References. All right, thank you very much.
Thank you. Great jobs. We have time for a few questions. Lots of people have them here. Let me start with this one. Would a person with a history of ketamine-specific substance use disorder be excluded from eligibility for ketamine therapy? And
I
let me part two is, would the psychotherapeutic induction of ketamine therapy potentially cause a rise in craving, obsession for people with a history of ketamine abuse?
Yeah, so I would exclude anyone that's had an addiction problem with ketamine. Thankfully, we don't see ketamine addiction all that often, even as an addiction psychiatrist. I've probably seen 15 cases in my 20-year career. It's ketamine is more often described as something people might use occasionally recreationally, but it is rarely the drug of choice or the problem substance, much like with other psychedelics too. We kind of often would get that history if a person has used it before. I have treated a number of people in long-term recovery from alcohol and opioid addiction. Those two combined definitely make up 90% of addiction cases that I treat, and I like to see at least a year of sobriety with solid recovery in place, but with continuing depressive symptoms that just haven't responded to traditional medications. So, I have seen good results in people that are, sober in long-term recovery and even ask me the questions that suggest they take their recovery seriously. Like they're worried about, is this a relapse? And, what happens if they're triggered? And those are all, to me, actually protective indications of a certain patient. And what was the second question?
Uh, well, I think kind of answered. Would the
Okay.
induction of ketamine therapy cause a rise in craving for people with a history of ketamine abuse?
Yeah, I think it would. Yeah.
And I think you sort of answered this one. It goes hand in hand, but since you have expertise in addiction and you just mentioned it, so if somebody is in a 12-step program, they're sober for a long period of time, and they choose ketamine, are they considered to be having a relapse?
I would say no, because it's a medication. It's not a drug in that context. Just like, oxycodone that might be given after a person has a hip replacement, even if that person has a history of alcoholism and they're in recovery and get a painful procedure that requires an opioid to reduce pain. I would also not call that a relapse. That's a prescribed medication, and hopefully the patient is open with their prescribing doc and saying, I have a history of this, just like I might have a history of high blood pressure or other medical conditions that a doctor should be aware of. But if it's done above board and full disclosure between patient and doctor, I do not call that a relapse.
Okay. This is probably my question. What are your thoughts about guardrails for abuse in general? I mean, I'm not saying it's exactly the same, but I went to college in the 60s and I went through, so the psychedelic experience was started by well-meaning, scientific, well established academics and researchers. So I worry about as this gets more not mainstream but acceptable, what that does to the abuse possibility, especially among young people. We in our treatment center, when they legalize anything, cannabis and so on, it's like, well, it's legal now, it's okay, and it turns into a whole new, abuse syndrome.
Yeah, I think the excitement about psychedelics being helpful for mental health applications, no doubt raises the awareness of psychedelics in the general population who might be eager to try it. Certainly, I have a lot of patients that tell me that they have tried it already, or they're thinking about trying it, or they have friends that have tried it and are, trying to get them to do it. So I think it's an inevitable side effect of the exciting research being done that people are, using it already on their own, and remains to be seen, how much of a problem that is and how it's addressed. But no doubt, I think those substances are being used more often because they're in the press every day.
You mentioned, and which I appreciated, your ethical treatments and your ethical, point of view from your clinic. And this question is, what are your thoughts on at-home? I think I know the answer, but what are your thoughts on at-home ketamine treatments? Clients who are doing a direct-to-home service that microdoses seems to have no oversight or real support, and concern about how that works.
Yeah, I think it's dangerous. These are serious medications intended to be used for treatment-resistant patients, which arguably need the most supervision and oversight. It's a function of the pandemic coming to us that got the DEA to suspend the laws requiring an in-person visit to prescribe a controlled substance. That caused a lot of telehealth companies to spring up that basically advertise controlled medications. So yeah, we see that with ketamine. We've seen that with stimulants like Adderall or Ritalin prescriptions available through telehealth companies that really specialize and do only that kind of work. And, it ends up being an easy way for people to get the medications under the guise of treatment. There are probably certain patients, like I was saying, that could be appropriate for home treatment, but they need to be carefully chosen, ideally not have any history of substance abuse. If it's done, have someone else in the home who's aware when it's happening. I've seen instances of, therapists being available via Zoom and doing like a Zoom session. So at least there's some supervision. There's just got to be a lot of parameters which don't currently exist with most of those models.
You talk a lot about psychotherapy integration. What is your thoughts? Like, clearly important, but is ketamine therapy workable without that, or is that a necessary part?
Yeah, most of the evidence on ketamine is it is fully effective and active as an antidepressant, just as a medication alone. So yeah, that 40-minute IV infusion, 6 treatments in 3 weeks, there are many, many studies showing that and only that is what's necessary for the antidepressant response.
Is there any research? I think TMS is also a treatment for depression that's been resistant to medications and so on. Is there any efficacy research between ketamine and TMS?
Not head-to-head trials, as I showed you with ECT compared to ketamine, but in their own studies, they're shown to be about 70% of effective in the treatment refractory patients.
If a person is abusing ketamine, is Spravato used to help them?
I think that's risky. A small amount of a substance that had been a person's drug of choice is the most triggering stimulus a person can have. And so I think in a treatment setting, there's just got to be something else that we try. Maybe we try TMS or ECT and not try the ketamine route.
Okay. Does ketamine reduce chronic pain from nerve damage caused by shingles?
It can, all sorts of neuropathic pain, yes.
Well, for any more, pretty much all of it. Great job. Appreciate your time.
Thank you.
And your expertise. Everybody's good. Thank you.
Yeah, thank you. And thank you so much for having me.
Sure. And thank you all for coming, and we'll see you next. Wait, hold on. Is there another one? No. All right. Thanks again.
Thanks.